video lecture for the textbook information related to Chapter 12. Chapter 12 is focused on the gastrointestinal and hepatobiliary systems. Your textbook authors begin by talking about the functionality of the system. They also talk about how ICD-10-PCS classifies it in terms of a character value. You don't need to memorize that D equals gastrointestinal system, but you do need to understand or review yourself in terms of your anatomy and what's included anatomically in the gastrointestinal system. When you go to the coding manual, you would index and you would get the character value of D for body system, so you don't really need to know that in terms of memorization. Same with the hepatobiliary system. We're talking about gallbladder, common bile duct, those types of structures that identify as part of a companion, so to speak, to the gastrointestinal system. Then your textbook goes on to refresh you on the functions of the gastrointestinal system. And those you should definitely be familiar with. And they are listed out for you also in your textbook, the very first page of Chapter 12. So one thing you can use these PowerPoint slides, you can access the non-audio version of the PowerPoint slides and you can print them out. Some students like to print them out to use some type of outline for the chapter information. That's just one tool that you could use them for. Some students also like to, keep the PowerPoint slides and maybe they don't have access to the textbook after this class is over. And again, one thing you have to think about is that you most likely, hopefully, will be preparing for a national exam, whether it's a coding exam or the RHIT exam, and you may want some of these elements to help you prepare to take that exam. And typically, depending on when you take the exam, how soon after you graduate, there's always going to be some element of review. You should spend some time reviewing your coding basics, even if you're going to take the RHIT exam. The next element of your textbook in terms of this chapter is organization of the system. They give you some graphical pictures. Again, as a coder, I find graphical pictures very helpful so that I'm understanding what the physician is documenting in terms of the clinical information in the operative report. So there's several pictures in the textbook chapter, and pictures figure 12.1, 12.2, 12.3. They also provide you with some definitions in your textbook of the various distinct elements of the gastrointestinal system, such as anal sphincter, mesentery, peritoneum, etc. You should know those definitions, and you should be able to discuss those particular organs, so to speak, or identify those particular organs in terms of being able to understand that when you're coding something. Then it moves into some of the distinctions related to ICD-10-PCS coding in terms of common root operations. Now, the textbook authors don't talk about every root operation. They talk about the common ones you find for this particular body system. And particularly because that the GI system has a lot of tubular body parts. There's 3 common root operations. That doesn't mean other root operations aren't used. That just means these are the ones that come up a lot in ICD-10-PCS coding for GI. So those are dilation, occlusion, and restriction. Also, bypass is a root operation that can be applied when patients have bariatric procedures. She also reminds you in your textbook, they list out for you some coding guidelines that could be applicable to GI system coding. Includes B3.2C, which talks about during the same operative episode, if multiple procedures are done with multiple root operations with very distinct objectives or intentions, That would be an example where we would assign multiple ICD-10 PCS codes for one visit to the OR. She also talks about the difference between anastomosis and bypass. Bypass is talking about from a coding standpoint. Bypass is talking about rerouting something, making a new connection or a new junction that's going to reroute or change how something is done internally in a person's body. Anastomosis is a reconnection. So they are not the same thing. And sometimes when we talk about patients having removal of part of their large intestine, sometimes they do bypass and sometimes they do anastomosis. So you need to be clear, one, on what's being documented, and then that impacts how you code it, because bypass is a root operation, specifically in ICD-10 PCS coding. But if a patient has an anastomosis, that's not a root operation. Depends on what's being done. But for example, if a patient is having part of their sigmoid colon removed because they have colon cancer, and the physician takes out a piece of their colon, sigmoid colon, and then just reconnects the two ends together, doesn't make any changes in the root, doesn't do a bypass, then that would be an excision, because he didn't take out the entire sigmoid colon, he took out a portion of it. So that's one example of the difference between those two surgical events that impact our ICD-10 PCS code selection. Then she also talks about bariatric procedures, gives you some terminology, and defines out very briefly what these mean in terms of, again, bypass is a root operation, excision is a different root operation. So every patient who has a gastric bypass is not going to have the same root operation. There's different types of gastric bypass procedures, so there could be different root operations. There's also different surgical approaches. So it's important not to, get into the thought of, okay, all gastric or bariatric procedures are going to be coded to bypass. That is not the correct level of thinking, because there's different types of procedures, as you can see here on this slide. Then she also talks about colostomy and ileostomies. I believe in the exercise review, you did the separate video, when I talked about the exercise at the end of chapter 12, I specifically mentioned a colostomy and gave you some information on that. There's exercise number 4 at the end of chapter 12, creation of a colostomy at the descending colon level. So please pay attention to that. A colostomy is basically changing the route. So a patient is no longer going to defecate the normal way. Most likely they have some type of rectal cancer, lower sigmoid colon cancer, and they remove that part of their intestine and that part of their body, and now the physician is creating a new route, a new pathway for the patient to now eliminate out into what is called a colostomy bag, and that is then a bypass. Sometimes a colostomy is permanent, and sometimes it is somewhat temporary. It may be for months, but it's not meant to be forever. And then the patient has basically what is called a reversal, but it's clinically called a takedown. So that's what she's talking about here, and that obviously is also covered in the chapter in the text, and also you're given some exercises so you understand how to code a colostomy. The next area she talks about procedure-wise is a myotomy. She talks about 2 different anatomical locations, the esophagus and the pylorus. One thing I will remind you of, which she talks about later, that ICD-10 PCS considers the pylorus, which is part of your stomach, a distinct body part. So you need to remember that as you're coding in the GI system. And also, here's a picture on this particular slide of an esophageal myotomy. The eponym is Heller, and the patient is having, the surgeon is cutting into this muscle-like structure. Remember, otomy, O-T-O-M-Y, means cutting into, and that's what we're talking about. The pylorus would be a different anatomical location down here in the stomach area. I talked about that in the exercise video again because we had some examples at the end of chapter 12. In the check your understanding, you have at least one example of a pylori myotomy, typically for a patient who has a stenosis. So again, just as like we talked about gastric bypass, all myotomy focused procedures where they're cutting into something in the muscle structure will not be coded to the same root operation. It depends on what's being done, and again, goes back to the intention or the objective of the overall procedure. Also in your textbook, she talks about dilation of the esophagus, other procedures. There's different kinds of dilation of esophagus. Sometimes depends on what's going on with the patient. She also specifically mentioned something called a Shatosky's ring. This is not a device, and this is important. I want to point this out because this is part of you need to understand this before you tackle the graded assignment for this particular lesson. A Shatosky's ring, as she notes in your textbook, is an anatomical fact. It's a way of talking about anatomical rings that are inside the patient's body due to whatever reason they got there, but it is not an external man-made device. It's a tightening of the mucosa of the patient's distal or lower esophagus, which is what is being showed here. They look like rings, but it's actual anatomical fact. It's something that happens in a patient's body. It's not something that someone puts into their body, such as a device or a piece of metal or something like that. So it's just something you need to understand and learn as you learn more about medicine and medical terminology. In this case, this ring is talking about an anatomical structure. So when we talk about procedures on the esophagus, we can have different kinds of procedures. She talks about two specific root operations, dilation and restriction, because again, we don't want to get into the idea that one thing is done on a patient's body in one area and it's going to always go to the same root operation. That's not true because there's multiple surgical events that could be done on a specific body part, and it depends on what's being done and how it's being done and what's being documented. Then she talks about volvulus, which is reposition. And again, I think there's an exercise on that, a non-graded exercise. So pay attention when you get there. That makes you understand what that means. Then she talks about fixation procedures and enterolysis procedures. And specifically talks about for enterolysis procedure that relates to ICD-10 PCS coding guideline B3.13 and the root operation release. The body part value coded is the body part being freed and not the tissue being manipulated or cut to free the body part. So we have this release, can be used in the GI area. We can also do a release. The other common operation you'll see release is a carpal tunnel release, which is a nerve in your hand and your wrist. So she's talking about the fact that when you're coding a release operation, whether it's the wrist or in the GI system, the body part value that you are reflecting in your ICD-10 PCS code will be the body part that's being freed up, not the tissue around it that the surgeon's actually working on. In your textbook then, moving forward, the next area she talks about is ulcer repair using something called a Graham patch. She talks about the fact that this is not a supplement procedure, but a repair. Because in this case, they're also using sutures and pieces of an omentum, which is an anatomical piece of the patient's body. So Graham patches, the surgeon uses an omentum patch to repair a peptic ulcer. And the omentum, the piece of tissue that he's using to facilitate this patch, is not disconnected. It is pulled up to cover and overlap, so to speak, the perforated ulcer location. And then in ICD-10 PCS, when the patch material is not completely disconnected from the source, it does not qualify as a device. So we can't code it for ICD-10 PCS practice and definitions at this point in time. We can't code this as a device. Then she goes on to talk about body parts. Again, these are anatomical information. There is guideline B4.8. In the gastrointestinal body system, the general body part values, upper intestinal tract and lower intestinal tract are provided as an option for the root operations of change, inspection, removal, and revision. Upper intestinal tract includes the portion of the GI tract from the esophagus down to and including the duodenum, and the lower intestinal tract includes the portion of the GI tract from the jejunum down to and including the rectum and anus. So she's giving you some of the divisions that when we say upper intestinal tract, what's included in that, and we say lower intestinal tract, what's included in that. Then of course, always one of the areas that we always seem to focus in on, because it does take a bit of practice. Again, coding is about practice. It's understanding your surgical approach. You don't memorize the character values, but the idea is that you understand what open is versus percutaneous endoscopic, etc. She also gives you a specific coding guideline that really does relate to this particular body system. When a patient is having a procedure that's documented as endoscopic assistance, sometimes they do Da Vinci, which is a name of an actual piece of equipment. When it's a laparoscopic assisted XYZ, whatever it is, that word endoscopic assistance equates to open. So the coding guideline B5.2 states procedures performed using the open approach with percutaneous endoscopic assistance are coded to the approach open. Then we have guideline B3.2D, which she also talks about two procedures. And again, if you go back to chapter 2, which was a little bit of a struggle at the time because we weren't coding anything yet. Hopefully some of those guidelines are making a little bit more sense. Coding guideline B3.2D reads, during the same operative session, multiple procedures are coded if the intended root operation is attempted using one approach, but is converted to a different approach. And the example they give you back in chapter 2 is a patient was planned to have a laparoscopic cholecystectomy. For whatever reason, once they got in there with the laparoscope, they decided to convert it to an open cholecystectomy. Then you would code that procedure, you would code that with the percutaneous endoscopic approach, inspection, and you would code the open resection because they opened up the patient's abdominal cavity to get the gallbladder out, which is what they're doing in a in a cholecystectomy. But they first tried to do it with the endoscope and it didn't work out. So again, that's back in chapter 2. The text of B3.2D is also your guidelines should be in the front or in some entry section of your ICD-10 PCS coding manual. Devices. Typically, again, in coding in ICD-10 PCS, your device character value reflects two things. if a device was left in a patient at the end of a surgery, so if the device is intentionally left in to help the patient function or fix a piece of their anatomy, or the other reason why we reflect the device character value as a positive is if there was already a device there and the surgeon went in to retrieve it, move it, take it out, or fix it. So in our GI system, we have devices common identified for you by your textbook author. She talks about the esophagus airway, and she talks about anal sphincters. Patients may have had some type of previous surgery. They may have had some type of pelvic floor dysfunction, and that's the reason why they would be having an anal sphincter. She also then talks about a gastric simulator. I gave you a little picture of one. It's coded as a pacemaker. It is considered a pacemaker for the stomach. It's a two-part device. It's implanted into a subcutaneous pocket of the abdomen near the stomach using an open approach, and two simulator leads are tunneled percutaneously to the surface of the stomach. Then she talks about qualifiers again, guideline B3.6a. Because again, as noted back in chapter 2, I believe, it talked about the fact that bypass qualifier value, when you code bypass procedures, the qualifier value means one thing in every body system except for when we do heart surgeries. So when we do bypass procedures in the GI system, the body part bypass from and the body part bypass to is what we're looking at. The fourth character value, body part specifically identifies the body part bypass from, and the qualifier specifies the body part bypass to. And again, this would be a factor specifically if a patient had a gastric bypass type procedure. Also, of course, don't forget that in order for us to apply the last qualifier value of X for diagnostic, the surgical event has to be diagnostic in nature. So they have to be not just sending something off to pathology. Anytime a patient has something removed from their body, they're going to send it to pathology. But the diagnostic component is this surgery is being done to get a diagnosis. So it's being done as a biopsy type procedure, or the physician gives us some clinical information that tells us that this is an investigative component of this procedure, this surgery event. That they're looking to send this piece of tissue off to pathology for analysis to get more information on a medical disease or a medical diagnosis. So that is all that I have on the lecture portion of this particular chapter. Again, you have a separate text document and video that goes over the check your understanding exercises at the end of chapter 12 and the odd numbered, what is called cases or operative report. The even number cases, number 2, number 4, number 6, and number 8 are part of the graded assignment related to this lesson. If you have any questions on this particular presentation, of course, you can contact me in 2 ways, via the forum, or you can inbox me directly in Canvas. Thanks for listening.